So it's a broad overview of radiosurgery from the radiation oncology perspective. I think I'll highlight some of the key points, really also echo some of the things that Dr. Mendel and other speakers will mention regarding really the importance of multidisciplinary discussion and decision-making for these spine metastases patients. We'll start with a case, a brief case, just to illustrate some of the points, particularly with modern cancer patients, modern radiosurgery options. This was a 40-year-old young woman, unfortunately with metastatic lung adenocarcinoma, but notably did have a EGFR mutation. So it was on an EGFR mutant targeted therapy. Had prior conventional radiation throughout the spine, so it had known history of diffuse spine metastases, but was admitted for worsening back pain. Basically was found now to have new epidural disease at T9, centered at T9. Basically, at this point, this is prior to the patient meeting me or Dr. Mendel. This is what the site looked like, was essentially just recommended by other providers, conventional palliative radiation. And not to say that that was necessarily the wrong decision, but just to illustrate what can happen. So this was the radiation dose, 20 gray and 5 fraction. You can tell this is conventional radiation from the radiation planning because the 20 gray dose, this blue line, covers everything relatively evenly. So the same dose gets to the spinal cord as it does to the tumor, right by in the vertebral body and in the adjacent area. However, 3 months later, there was rapid worsening of new back pain. This is the scan MRI at T9, and you can see that both on T1 and T2, there's now actually disease that's progressed despite the conventional radiation. So not, I would say not common for this kind of histology, but absolutely can happen with conventional radiation. The patient underwent surgery. You can see the instrumentation and debulking of tumor at T9. Now, we knew that with this relatively radio-resistant case, we need to give postoperative radiation, but now using a much more complicated technique with radiosurgery to really dose escalate radiation, especially in the re-irradiation setting next to the spinal cord. This was myelogram that we had to use because, unfortunately, we did not have carbon fibers at this time. I think Dr. Mendel brought it after the case. Myelogram was able to visualize very clearly, but now that we have CSF restored circumferentially around the spinal cord, we could safely deliver radiosurgery, re-irradiation with high dose to the tumor, residual tumor, and areas of microscopic disease concern, but then lower radiation to the spinal cord, which again, it's completely different from conventional radiation. This example of the radiosurgery plan, you can see these concentric circles of increasing dose from the spinal cord to the area of microscopic disease concern. And this is certainly the hallmark of spine radiosurgery. So, summarize some of the key roles of radiation oncologists in these settings. So there's certainly the basics where we meet the patient, we can recommend radiation, conventional radiation especially, which is bread and butter for most radiation oncologists, but also potentially radiosurgery for the specialists and experts. And certainly, design the radiation, monitor side effects during radiation. But I think there's a lot more that we do and can do as radiation oncologists as part of a big team. So first, I think just appreciate really the nuance and breadth of cancer types, right? I mean, different cancers behave so differently with different systemic options, radiation, and even kind of the relative need for surgical debulking, ranging from lymphomas and myelomas on the other end to really radio-resistant histology, sarcomas, renal cell carcinomas, melanomas. Appreciate the radiosensitivity, but also, what are the other options available? Sometimes if it's a patient with cancer pain, but the medical oncologist says, you know what, there's great second-line option available. Sometimes if the pain's not bad, there's no epidural disease. That's something to consider. Patients not taking any pain medicine or prescription pain medicine. Needs to say the multidisciplinary conversation is so critical. I speak with Dr. Mendel all the time regarding spine tumor patients to really come together with the consensus. And sometimes it's other specialists as well, the neuroradiologist, the interventional radiologist. And a lot of these patients are inpatients, and the inpatient team managing the day-to-day, understanding the condition of the patients, what's the urgency, that's also a critical part of the clinical decision-making. And then in metastatic cancers, understanding the patient's history, the treatment course, What is prognosis? I think that's a huge part of some of these decisions for the stage 4 patients. The patient's on hasn't even started first line therapy, then yeah, we oftentimes like to give patient the benefit of the doubt. But if the patient they're failing third line, fourth line therapy, they're failing their second phase 1, clinical trial, and the medical oncologist says, I'm worried that the patient basically has probably weeks left, that clearly will change our recommendation as well. I also want to add that we generally, especially me seeing a lot of metastatic patients, we develop a lot of expertise in terms of trying to interpret the symptoms of the patients. Where is the pain coming from? Is it tumor pain, mechanical pain? And sometimes these patients have so many different metastatic lesions on scans. Which lesion is causing the pain? Because that's part of our job as well, to really target focally. I always say with patients with radiation, we can't treat like the entire spine. We have to really isolate what are their levels causing symptoms, where do we need treatment, and really ignore the other areas. Finally, keeping up with current evidence, I think that's huge. What's the evidence for radiation escalation with radiosurgery? And what's the evidence of doing it in patients maybe even without symptoms? And that's something that's relatively new that we didn't have, say, 10 years ago. Related to that, just because we've always done it doesn't mean we should continue doing it. So the dose escalation with radiosurgery, does that make sense clinically? Using ablative radiosurgery or other techniques to treat oligometastatic patients where they only have 2 or 3 sites of metastatic disease, they're young, they're healthy. Even without symptoms, we could treat all 2 or 3 sites with radiation or surgery and radiation. But on the converse, the opposite philosophy, just because we can do this treatment doesn't mean it's best for the patient, right? And so taking account the prognosis, taking account what's the evidence available, I think a huge part of the decision making. Radiation, what's different about radiosurgery? Very quickly, radiation 20 years ago was 2-dimensional. It used X-rays to design the radiation plans. Then once CT scans became an integral part of the radiation planning, we still do, every radiation patient basically get a CT scan to help plan the radiation. We can now plan radiation in 3 dimensions. The advent of really modern computers and computer algorithms allow us to use IMRT radiation, which, long story short, we're able to really shape radiation in much more conformal fashion than even 3-dimensional radiation, where there's just 3 or 4 fields delivering like a box or a very rudimentary shape. Radiosurgery is even the next step, where instead of conventional radiation, where we deliver low doses to large area over many sessions, sometimes conventional radiation was 6-7 weeks of radiation. Radiosurgery is the complete inverse, where high doses per session, 1, 2, 3, 4, 5 session, very pinpoint, using very, very modern techniques to localize the radiation. Talking a little bit about developing and really growing the radiosurgery program, from the radiation side of things, really requires a lot of specialized experience and at least appreciate the nuances of spine radiosurgery, as well as some important instruments. So mentioned the teams, and even within the radiation department, there's a lot of other specialists, dosimetrists, physicists, radiation therapists. I think it's important that they appreciate, if not have experience with spine radiosurgery, because we really are using radiation plans that have the fastest dose change, or what we call dose drop-off, within a couple millimeters. So having the finest, compared to other cancer sites in the body with radiation cancer sites, the most precise localization of radiation before and in the middle of treatment, the most precise planning, but at the same time, always respecting the spinal cord radiation dose limitation. That's something where I have colleagues who are saying, I want to build a program. We've never done this before. Can we adapt essentially radiation philosophies from other sides of the body? And I basically, to summarize, I say no. I think you really need to appreciate that there's important differences, and in some ways more gravitas with spine radiosurgery compared to rudimentary, palliative radiation, especially, but even lung radiation or breast cancer radiation. The patient selection is huge with radiosurgery. So our spine tumor board that Dr. Mendel, we essentially started at Yale, really important but efficient way to identify patients who are good candidates for radiosurgery. Mentioned working closely with the other specialists. And I think also from the programmatic standpoint, establishing really good lines of communication with the medical oncologists, because and this diagram shows what happens with brain metastases, but I think very similar to spine metastases. We certainly have patients with first-line presentation. A lot of times they're admitted, they're inpatient, and that's one way that patients come to find us. But another very, very common, in some ways more common, is patients have known stage 4 cancer. They have an ongoing treatment with medical oncologists, and it's really the medical oncologist identifying why there's a new symptom or new finding on the scans and communicating to Dr. Mendel and myself, and seeing, do we do radiation, do we do radiosurgery, do we need surgery? So that's a really important part of the program. But at the same time, once the patients have had surgery and radiation or just radiation, following up with the patients, managing toxicities, and really, continue the communication with a medical oncologist, really to provide great patient care that allows the medical oncologist to feel confident in continuing to refer patients to us. Some of the examples of specialized equipment. This is for when we do radiosurgery to really the lower thoracic spine or lumbar spine. This is the vacuum bag the patients lay on top of. We keep it and we have the patients lay in it with every treatment. And anteriorly, we also have this vacuum bag we call body fix. And that's been shown to be able to further localize patients more precisely. For cervical spine, upper thoracic spine tumors, we use this Brainlab head, neck, and shoulder mask. And this mask also allows us to give specialized intra-treatment localization with arrays detectors in the radiation machine room. Just a quick example of radiosurgery plan on the left compared to the conventional radiation again. Very fast dose drop-off between the spinal cord and the tumor that's treated. This I'm trying to show when the radiation treatment plan is designed. This is the complicated computer algorithm. As the gantry or the radiation machine rotates around the patient, this is literally what's going on with the radiation field. So this is not something that was available 15 years ago. And what happens is when the computer designs this for the patient, we always need to basically test this plan on the radiation machine before we actually start the radiation treatment. This is called the radiation QA process. This is one of the reasons why, in the perfect world, we could give radiosurgery like soon after we see the patient, but oftentimes it normally takes actually 1 to 2 weeks, if not a little bit longer, because of the modern computers and the modern need for a QA process. With the spine radiosurgery machine, they're just special detectors that makes it different than our normal radiation machines. This is just an example. In the middle of treatment, we can actually take these orthogonal x-rays. This is obviously a post-operative spine radiosurgery case, and you can see we make these what we call shifts within just a couple millimeters to really fine-tune before and in the middle of spine radiosurgery treatments. Basically, spine radiosurgery compared to conventional spine radiation allows us to give more radiation dose to the tumor. That's really the fundamental idea. From a radiobiology standpoint, an estimate of anywhere between 2 to 6 times more radiation dose. So hopefully with better local control and symptom relief. How we pick patients, certainly radioresistance histologies, mentioned sarcomas and melanomas. If there's been prior radiation, like the lung cancer patient case at the beginning, we use radiosurgery because we already know if it came back after conventional radiation, this is a more radioresistant histology case. Some complicated spine metastases, especially the mass-like tumors with significant extraosseous extension, we know just with conventional radiation, especially without surgery, they have a much higher chance for local recurrence. So we'll consider radiosurgery as well. And then mentioned the oligometastatic situation. It's a young, healthy patient, new metastatic disease, but only, say, 2 sites of disease on a PET scan. We'll absolutely consider upfront radiosurgery, even if there's no significant symptoms or epidural disease. But emphasize really requires that multidisciplinary evaluation. Just examples of radiosurgery before. You can see the epidural disease, and then this is a plan, and then after treatment, before and after, just significant improvement in epidural disease. This is not the average case, mind you, but it absolutely can happen. And so this is obviously a great result. Some of the evidence I cite that's important to mention. So we do have randomized evidence now that using radiosurgery compared to conventional radiation, this is a Canadian, the SG24 study, showed that patients were randomized to radiosurgery compared to conventional radiation. These were metastatic patients without oligometastatic disease necessarily. So different histologies, but diffuse metastatic disease. That patients essentially at 3 months and 6 months had significantly higher chance for complete response of pain relief. Okay, and then coupled with that, it seemed like the change in SIN score from baseline before and after, along with grade 3, grade 4 toxicity, is really not that different between conventional radiation and this spine radiosurgery. So really relatively high quality trial, finally giving us prospective randomized evidence that higher dose of radiation with spine radiosurgery absolutely can lead to better pain relief, as well as really not that much more toxicity. We know radiation dose matters. This is also from the Canadian group, show that when they give higher doses of radiosurgery, 28 gray compared to 24 gray, the cumulative local failure rates were lower. In their study, they did not observe, this is retrospective, higher rates of vertebral compression fracture. However, we do know this, I think echoes what Dr. Mendel had mentioned, that when we do radiosurgery with higher doses, this is the memorial information, we do see higher risk of compression fracture. So clearly one of the things that we have to look out for after radiosurgery. When we look at exclusion criteria, one of the main key things that we always consider is if there's already instability. I don't want to go into detail because we'll have other experts talk about this, but absolutely, if the SINS score is high before consideration of radiosurgery, it is not a good option, right? Whether it's surgery or some kind of stabilization technique, absolutely things to consider. Other things, poor prognosis, if there's a significant core compression, radiosurgery is not a good option. This is just showing that when they do surgery is done for patients, and then radiosurgery is done afterwards. The amount of epidural disease clearance clearly matters and predicts for local control. And this is certainly very intuitive, right? Because when we do radiosurgery, we have to reduce radiation dose around the spinal cord. That is the fundamental goal or idea behind radiosurgery. So if the epidural disease is not cleared, what you have is you're essentially underdosing tumor that's right by the spinal cord, and you're at very high risk for having tumor grow around the spinal cord. And so the quality of surgery, a huge part of really the determination whether post-operative radiosurgery is an option. And in practice, what I say is before surgery, I tell patients radiosurgery absolutely could be done after your surgery, but we will always decide based on post-operative imaging, whether that be post-operative MRI, if we have carbon fiber, whether that's based on myelogram. Because if there's still tumor by the spinal cord, I do not generally think radiosurgery after surgery is a good option because we are at risk for underdosing tumor around the cord. Finally, I'll leave with some additional important evidence. This is the SABRE-COMET randomized trial. It's a randomized phase 2 trial, not a big trial, about 100 patients or so, but basically multiple cancer histologies. These are all patients with oligometastatic stage 4 cancer. Patients were randomized either to standard treatment, which is just essentially systemic therapy. A lot of that times that's chemotherapy, or ablative treatment. A lot of these patients receive basically radiosurgery, and these are not all spine metastases. Some of these had, say, bone or lung metastases. But this trial, a proof of principle, showed that patients who got radiosurgery to all sites of disease up front actually live longer. So really cool proof of principle that even treating asymptomatic oligometastases can lead to better cancer outcomes in the long term. I do bring up kind of a counter example. This is a more recent result from a national trial, NRG BR002. Now, these were all only breast cancer patients with oligometastatic cancer. Essentially, this showed that their survival was not different when they treated all patients up front with oligometastatic disease and radiosurgery. And so in this case, people theorize, right? Maybe the standard treatments for these breast cancer patients, particularly the hormone positive patients, are just so good that doing ablative treatment up front may not make a big difference in the at least initially. But both these studies came out in the last couple of years. It shows that the evidence is continually evolving whether to do oligometastatic radiosurgery or whether to hold off or to only do it in a setting of symptoms or other issues. So I'll end by summarizing, modern spine radiosurgery. It's really a highly technical, specialized tool. There are absolutely expanding indications, but does require an important multidisciplinary evaluation. So spinal tumor with neurosurgery, with radiology, neuroradiology, and really in a center that has either experience or just appreciation for how it's unique and different than just really conventional radiation. Obviously, collaboration between neurosurgery and radiation oncology is so critical for these spine patients. Which really, in my experience working with Dr. Mendel. For patients who get surgery, the debulking of the epidural disease is essential to allow for a postoperative radiosurgery. And now we have increasing evidence that we have better local control and better rates of pain control with radiosurgery. But obviously, in the big picture, patient selection between us, radiation oncologists, neurosurgery, medical oncology, and sometimes the inpatient teams, just so critical. And so with that, I think we'll end it there.
Thank you, Jan. This is wonderful. Great stuff. Couple of naive questions from the simpleton here in the front row. And we're joined by Dr. Amin, also from UW, sitting right next to me here. So the first thing is physics of high energy impartition. Have we made advances? I'm always confused when some people in your field tell me, oh, this needs neutrons, or oh, this needs photons, or this needs this, needs that. I'm easily confused, okay? But I'm particularly confused when they start hitting me with the various particles that can impart greater benefits. So is there some rationale that we can all kind of impart for the pedestrians in the field like myself?
Oh, a great question, Dr. Chapman. So practically, there's really two options. The most common is photon, and that's 99.9% of all treatments for spine. And then the really rare alternative is a photon particle treatment, and that's so there are only select centers around the country that offers that. With other heavier particles like carbon, that is under investigation, but in the United States, that's not something that is done. So it's really either photons or protons. The main dosimetric advantage of protons is that when the proton radiation enters the body, it can allow relatively low dose of radiation before and after the target, versus with photon radiation, the conventional radiation, we have dose enter the body and continuously give off dose in each individual linear line. Now, we make up for that by having the radiation come around like a circle. That's why the gantry rotates like a circle around the patient. Where I think practically where protons could be considered if it's a very young patient with good prognosis, like a benign histology in someone who's like 20 or 30 years old, and we're worried about secondary cancer 30, 40 years later, then I think spending the time to see a proton center could be a good option to really reduce low dose scatter radiation to like a young lady who is worried about much higher risk for breast cancer 30 years later. I think in some situations like chordomas, protons can offer benefit if it's right next to brainstem or right next to spinal cord, just to try to escalate dose a little bit higher than even conventional radiosurgery. But I think for the most part, photon radiosurgery is sufficient. It's really rare that we really think patients should travel, and that's our bias in Yale. Should travel to really consider a proton spine radiation.
Then my follow-up question. Oh, sorry, Dr. Bilski has points.
Oh, please go ahead. No,
No, you go first. You're way more impactful.
Not really. That was an absolutely outstanding talk. Thank you so much. The question I have, and we're sort of struggling with it now, is transitioning potentially for some of our patients from myelo-CT sim to MR-CT fusion. And one of the big, when you use a MR-CT fusion, either upfront or after peaks put in, are you increasing the PRV on the spinal cord to protect it? I think we're putting another millimeter or two margin. And the second question is, if we do that, are we going to start to see more recurrences in the epidural space based on, conformality around the dura?
Well, Dr. Bilski, that's the million-dollar question. I would say in my practice, I do it case by case. I look at how confident I can visualize the cord based on MRI and or myogram in select cases. I would say by default, I've been using 1 millimeter PRV. I know some people use more and some people don't use any. Obviously, if the clearance is fantastic and you have CSF throughout the cord, I would expect a very low risk for recurrence. But it is a challenge. And part of it is, even if we don't have the PRV, a lot of times the dose next to cord, because we will always prioritize the true cord dose, you're already getting lower doses in the close proximity, right? So right now, I do it really case by case. If I have any doubt that the fusion or the artifact or just something is not perfect, I will add 1 millimeter.
Right. Yeah, I just have a feeling, this is purely anecdotal and not I think colorectal is probably a less good responder in general. I think we just saw that on a recurrent series that we had and such. So I don't really know, but I just have the sense that when we started to transition to more MR-based CT fusion SIMs, that we're starting to see more recurrences epidural. And I think we're going to have to prove that, but I think part of it is we're just not as confident in that, dose delivery around the dura, but not sure. I just wondered what your experience was. Yeah.
Well, I think Dr. Brooks, the other idea, especially with the carbon, the peak demonstration, is that I wonder if it's, I mean, obviously there's symptoms and clear progression, but maybe one can catch things better when you don't have artifact from titanium or other hardware. So
Yeah, I think we're seeing it in the upfront too, with no hardware. I think it's just, there's no confidence in where the cord exactly is, and it's such a big dose. But yeah, peak has definitely made it better. Maybe we are seeing recurrences earlier and better and such. Yeah. Thank you so much. What brilliant talk. Thank you so much.
appreciate it.
So let me segue in a second to Professor Bernhard Meyer in Munich by asking you, Dr. Jan, about complications. So does SBRT done in conjunction with surgery, either before or after, lower my surgical complication rate by having a more diffuse entry portal and more diffuse and less focal soft tissue trauma? Does my question make sense, Dr.
Oh,
Jan?
is it to me? Oh, I apologize.
So does SBRT lower the complication rate of surgical approaches? I mean, infection historically was almost 30%. Dr. Meyer will talk about that in a second, but does that actually have a tangible effect on being able to do surgery earlier after radiation or doing radiation earlier after surgery, conversely?
That's a great question. I would say no. I mean, the skin dose might be marginally lower, but because we still get the dose gets higher and higher as you get closer towards your target. You're still going to get enough dose that we do not change kind of how long we wait. Certainly, we always clear with like Dr. Mendel, usually at least 3 weeks after surgery. I would not. The skin dose is not different enough where we have changed our path.
So what is the waiting time? You said that briefly. I just want to emphasize
At least 3 weeks, but it's case by case in the sense that a lot of times we'll wait for the postoperative evaluation. The other thing I think that's very critical to mention, I think I alluded to this, radiosurgery does take longer to plan. So without expediting things, it usually takes us around 2 weeks from the radiation planning scan to when we start the radiosurgery. So what that means is even as we're waiting for clearance, we're already getting started in terms of the planning.
Great stuff. Thank you again. Almost on time, and this was really cool. Live from Munich, I'm heavily conflicted about our next speaker, Professor Bernhard Meyer.